I am very pleased to introduce Dr. Cheryl Forchuk, who I heard speak a couple of months ago on the subject of our citizens who are without homes. And she brings an academic perspective, a studied perspective, having she and her team having done qualitative interviewing all across Canada in 28 communities involving 400 individuals and also focus groups involving 200 service providers for these of our citizens. Dr. Forchuk uh, sits in a lot of chairs, it seems. She is the research chair in aging, mental health, rehabilitation, and recovery at the Burrell and Richard Ivy Foundation. She is a professor of the Labatt Family School of Nursing at Western and is herself a PhD in nursing. And she is a scientist and assistant director at Lawson Health Research Institute. Her interest in mental illness, poverty, homelessness, and the connections between all of these things I was gripped by what she had to say. She can comment on a national level about how we got to this situation. I think she will tell you we were not always in this situation. And she will have some thoughts about potential solutions. So with all of that, over to you, Dr. Forchuk.
Thanks, Lynn. And Cheryl is fine. And
Cheryl.
I'm going to try for the sharing right now. So we'll see that it works. One of the things maybe I will speak to at the start, given as well with Lynn's comment, one of the things I do often hear from people is that people think we have always had a homeless problem, particularly younger people. They don't recall how recent this is. One of the reasons, like tomorrow, as I've done for over 20 years, I'm meeting with the psychiatry residents. So these are people who are planning on becoming psychiatrists and still in their traineeship at the hospital. And when I tell them that we have not always had the problem, they're often surprised. And similarly, when I talk to other students, when I talk to some of our student nurses or our younger people. But as a nurse, when I previously worked for many years as an advanced practice nurse in Hamilton at a psychiatric hospital, if we had a patient discharged to homelessness, it was the same form that we would fill out as a patient assault. That's how seriously that would be taken. And I do remember a number of years ago where it happened twice in 1 year that we discharged somebody into homelessness. And it was considered so disturbing that we had a huge meeting trying to figure out what was going on. How had we twice failed people within 1 year? What did we need to do about that? And then fast forward a few years after that, I was doing a project on, it was looking at discharge practices. I had 6 different psychiatric hospitals across the province were included in that. And we had an intervention and then a treatment as usual group, and we were following people for a year at each of these sites after discharge. And across all 6 sites, we were finding some people having left hospital, and sometimes immediately having left hospital, were homeless. So clearly something serious had happened. But at that point, I wasn't quite sure what was going on, but I certainly knew it wasn't good and that it was concerning. When I spoke to the staff, I'd say, what's happening that we're finding people in shelters where this has not happened before? And I found at the time, people would often drill down to individual issues. Oh, they don't have a housing history or tenancy history. They don't have the housing skills, but it doesn't make sense that across the province, all these people simultaneously lose housing skills. At the same time, I was also getting requests from some of the community agencies with concerns about this issue. And I did say, I often mention if I wasn't getting the message there, I also had a teenager, a friend of my son, whose mother had schizophrenia and ended up losing her housing. And then the son ended up in our basement for a fair bit. So clearly something had changed. So we ended up getting together a number of the community agencies, the people working in the mental health field as well, trying to understand what was happening, what were the shifts. And a lot of it really boils down to often the kinds of silos they work in. So David and Lynn, did that come through already? So it has arrived. So we started working together and developing a Community University Research Alliance to look at this issue. We've done it twice. And this is going back over 20 years. So just back up a little bit on the slides. So okay, next, go down one. Is it a right or a privilege? And I think you're probably aware that housing is a privilege, that there is a UN proclamation about housing as a right. Canada has signed on to that proclamation quite a few years ago. And Canada has already actually been investigated a couple of times for their poor housing policy. Go to the next slide. One more day, yeah. And one of the things, just to remember, that when you lose a home, try to think about all the things that are involved with what it means to have a home, what it means to lose a home. Becoming homeless is actually a very traumatic event, because it's not just losing the roof over your head, it's about all your possessions. They become limited to what you can fit into a knapsack or a very small something that you could carry or would be portable, or a grocery cart, but that's the limit of your. So you end up losing most of your clothes, your pots and pans, being able to safely store food or even have that very accessible. And as I say, there's often trauma that precedes the homelessness, but regardless, becoming homeless is very traumatic. And if you think of all the things in your home and what would be the meaning of losing that, pets are often a big issue. This is just an example of, this was taken a few years ago, actually, at Men's Mission. And some of their areas have more privacy than this. Some of them do not. In London, we've got some of our shelters are actually pretty good with the privacy in terms of single rooms. But many shelters look more like this, and in some other areas, particularly where people are relying on, say, out of the cold programs, church groups that are really struggling to do it, those mattresses would be on the floor. They wouldn't even be raised like this. People are often afraid of losing their possessions, so even when they go for a shower, they might bring in everything with them. And one of the another nurse who's done a lot of work around homelessness, was a street nurse for many years, Kathy Crow, who is in Toronto, did a study looking at the distance between the beds, the number of beds per washroom, like toilet facilities, and found that most of the shelters in Toronto did not even meet the minimum requirements for a UN refugee camp. And yet this is where people end up staying. And of course, this is where people often end up avoiding shelters. Go to the next slide. And of course, since COVID, we certainly have seen, we've always had some people preferring to more sleep in the rough, but I think the whole issue of encampments has certainly increased with the raising of housing prices and the pandemic that have really fueled, but particularly the rising prices. And I'll come back to that next slide. Can you go? Okay, thank you. So one of the things I often hear is a reason. In some ways, it's a reason to do nothing. It's kind of like the poor have always been with us. There's nothing we can possibly do about it. It's just too complicated. It's a wicked social problem. And really, it's not that complex. It is difficult to address, but it's not that difficult. If you can understand the game of musical chairs, you can understand the dynamics related to homelessness. And so next slide. So, and Jake, can you just go through a couple because it's just showing the game. Just get to the print. So in the game, I want you to consider that the chairs are the affordable housing in the community. And there's many definitions out there of affordable housing. And a lot of what we rely on comes from Canada Mortgage and Housing Corporation, which talks about that you're not spending more than 30% of your total income on housing related costs. So that might include rent, utilities, or mortgage and utilities, but all housing related costs would not be more than 30%. But the problem I find with this definition is it's kind of blind to the total amount. Because if you had $100,000 a year and spent 30 on housing, that's not the same thing as having 10,000 a year and spending 3 and then having only 7,000 left. So what I suggest is what housing would actually be accessible to those people who are living in poverty. If you were on Ontario Works, what would be available? If you were on Ontario Disability, if you were on old age security, if you're at that level of income, what housing in the community is actually available? So then in the game, the people circling around are the people who are actually living in poverty. So the people at those income levels. So clearly, if there's fewer chairs than people that need the chairs, that gap, that difference equates to homelessness. Now, the other thing about the game of musical chairs is there's music. There's music that is playing that starts and stops, and you lose your housing when the music stops if you are not able to quickly grab a chair. And I want you to think of the music as like when you think of music, music is really about transitions. And it's during periods of transition where people become vulnerable to losing their housing. Like even if you're at low income, but you are in a place that you could afford, even perhaps with great sacrifice, you might be able to afford to stay there, but not to eat. And are you going to food programs? But it's where you may have a transition point. For some people, and this I found very disturbing when I started working in this area, that could include things like leaving hospital, being diagnosed with a chronic illness. It could be losing your job. It could be aging out of children's aid. It could be retirement, being fired, going to jail, coming out of jail, relationship breakups. When you think of it, there's many transition points where you are vulnerable to losing housing. So from a prevention perspective, you can think of the times that that these transitions occur and how to support people. And I'll be giving an example later how we support people to prevent discharge to homelessness. But the thing is, that doesn't change the overall number. It may prevent a new person from becoming homeless, but it's still, you have to either deal with the chairs or the people circling if you're actually going to change homelessness. um, Preventing more people from going in there. It's really, those strategies are about specific groups of people, but it doesn't change the overall picture. That requires increasing the chairs or decreasing the people. Next slide. So this just shows you how bad some of the chairs are right now. I'm using some slides around Ontario Works. And the reason, I'm sure you hear this kind of thing all the time about somehow people are getting rich. When someone's on Ontario Works, it is similar across the country. The actual rates of income support are quite similar across the country. And in every case, it's broken into two portions. One of them is what's called a shelter allowance. And I apologize if people are already aware of it. And then the other part it is for your other living costs. So for example, of your for the shelter allowance portion of being on Ontario Works, you are expected to find
on homelessness.
you are. I think somebody should go on mute. You're expected to be able to find housing, including all utilities, for $390 a month. Anyone aware of any place in London like that? Probably not, right? And probably not in most places. If there's two people living together, and if you see, like, even in terms of how you're adding it up, you actually lose a little bit, but you might have a slightly better chance. 642 for the shelter allowance. But again, I don't think you're going to find it. And one of the things I often hear, oh, people are having kids so they can get more money. Well, if you have that one baby, you got 697 for your shelter allowance, and you can see how the numbers go from there. I don't think anyone's getting rich by having more kids or any of this. And then just move to the next slide, because the next slide is the basic needs amount. So you get these two amounts, the one for the shelter allowance and then this other money for the basic needs. So this is supposed to cover your food and everything else. Well, as you can imagine, so somebody with no children that would get that. So then that would be like that 343 on top of that basic needs. If you've got one child, then that's 360 on top of the two-person home, etc. So if you look at how much extra you get per child, and I just say this because I get very tired of hearing people talking about how people go on welfare and have kids to make money. Because I think if you do the math, that actually makes no sense. And very few people who are on Ontario Works would actually be able to simply use the housing portion for housing. They have to end up going into that basic needs allowance and then finding alternate sources for things like food and clothing. Move down, please. And as I say, these rates are very similar across the country. Generally, by the time you add the two together, most places across the country for your housing as well as your basic needs, you're talking in the ballpark of $800 a month to find a place to live, eat, have clothing. So highly unlikely. Next slide. So what are some of these things that can be done about it? One of the issues that when we talk to people who are homeless, it's really important, and this is why I take this time to begin to understand this as a systems failure rather than a personal failure. People come up with solutions like, oh, we should be teaching people how to budget better. Well, I don't, if you got $800 a month for everything, it's not a matter of budgeting. And as well, the idea of things needing to cross sectors and advocate for, when we're talking about advocacy, it's got to either increase the chairs or decrease the people circling. And we're going to go to the next slide. So the next issue is around examples of increasing the chairs. And one of the most common ways, not only in Canada, but elsewhere, is about public housing. Because really, when you're looking at that level of income, you're not going to get that level of income on the private market. It's going to be in public housing. Something else that has been used, including here in London, is the use of rent subsidies. It's basically a top up to the amount to allow people to be able to afford housing. And I just gave a couple of examples, some of our projects with homeless veterans in order to have them live in the neighborhood of choice. We were with the city, that project looked at some subsidies. We had another project with homeless youth, and I know you've already mentioned in your report about how great the Sisters of St. Joseph's are. When we talked to the youth, they also were very much wanting to get out of the downtown core because of the proximity to drug and sex trade. That was making things difficult. And when we talked about how much we were having for the vets, they said, no, all we would want, because we had, again, it's participatory research. We had homeless youth sitting around the advisory group problem solving with us. They said, what we need is $50 a month. A difference of $50 a month would get us out of the downtown core. Maybe it's just renting a room, but at least it wouldn't be a room downtown. And we had Ontario Work sitting around there who said that there was an exception because a lot of funds get clawed back, but that if it was a gift from a religious organization, it would not. So Sisters of St. Joseph stepped up and provided this $50 a month, which is only $600 a year. And almost all the youth in that project only needed it for a year. We had a few that needed it for 18 months. And the reason they only wanted $50 is they felt that once they got themselves settled in a situation and could get some employment, they could make up that $50. But if it was a higher amount, it would be difficult. And if they couldn't make it up, they would lose their housing again. So we had a few that went 18 months, and those were primarily youth that themselves had kids. We've got many other examples too, but a lot of it is around creating housing options. So let's just move to the next slide. And there's been a lot of work in very many different areas that really illustrate that it's actually more expensive to leave someone in a state of homelessness than to house them. So it is expensive, just as in our personal budget. Housing is expensive. It's one of the most expensive things in most people's budget. And so for municipalities as well. It is expensive. And I should say, I often go through this. I took out a few slides knowing we had a little bit less time, but I will mention Canada is the only industrial nation that does not have housing at the national level. We did have that till around 1990, and then it was downloaded to the provinces. And this is really where we lost a lot of housing stock because we had a number of years the provinces did not want responsibility for housing, so they were not building public housing. If the shovel wasn't already in the ground, the housing wasn't built. It was as few as 1,000 new public housing units, not buildings, but units across the entire country in that period after that. And then in Ontario, I always say we looked at a bad idea and thought, well, how can we make this even worse? It was downloaded to the municipality. So if you go in London, there'd be buildings that used to say Canada Housing, that then became Ontario Housing, and are now London Middlesex Housing. This relates to that downloading through different layers of government. But with each stage of downloading, the actual creation of public housing has really gone down. Now, there have been some recent shifts in this. Canada Mortgage and Housing Corporation has again, in some of our recent budgets, we are seeing money now flowing through, and we know London, for example, has got money both provincially and federally in terms of creating more housing. But this is going to take us a long time to catch up for a situation where we've had, in many cases, decades of a lack of investment in public housing. When it was downloaded from the province, that was in the Mike Harris period. Any of you as old as me probably remember that omnibus bill. So it was part of that omnibus bill that we're still paying for in many ways. But the other thing was, not only was it downloaded to the municipality at that point, but municipalities had the option of opting out. You could say, hey, we don't have poor people in our community. We don't need a public housing. We don't need a homeless sector. And so what ended up happening is a lot of our smaller and more rural communities chose to opt out. And these communities very often had very little rental property on the private market. Since there's a much greater emphasis on home ownership in your smaller and more rural communities. So this has also created problems and has created some migration problems between communities because of that total lack. So anyway, that slide shows you some of the many costs related to keeping someone housing. CIHI's Canadian Institute of Health Information, they collect information from all the hospitals. All the hospitals are mandated to send sort of like a minimum data set to CIHI. And a few years ago, they added something on whether or not somebody was homeless or not. I had the privilege of working with CIHI on this report, which is the first report looking at that data. And basically, anyone that comes in homeless is going to be sicker and therefore take twice as long in hospital, and it's also much more likely to be readmitted. And when you just think about how difficult it would be to maintain your health when you're homeless. If you're diabetic, how do you store your medication? How do you keep your medication in a safe place? How do you get a good sleep at night? How do you maintain your nutritional status? So people end up getting sicker, and when they are sick, it takes them a long time to recover. Next slide. So basically, decreasing the people circling is any anti-poverty strategy is going to decrease the people circling. So when we're talking about actions, as I said, it's increasing the chairs, which is primarily around things like public housing, but it could also be things like how easy is it to put in a granny suite or to rent a room in your house, anything that increases the housing stock. But decreasing those people circling are around any anti-poverty for example, increasing the rates of basic income support, disability support. I remember the Ontario, from the Provincial Nursing Association, Registered Nurses Association of Ontario, and we've been calling for a couple of years that for people on disability, instead of getting around $1,200 a month for someone who's disabled, cannot work due to a physical or mental disability, that needs to be doubled. But again, this has not yet happened. We can do things like preventing the start of homelessness. It's much easier to prevent someone from being homeless than someone who has already been homeless for a period of time, to get them to a point of feeling comfortable and safe. It takes much more time than preventing the problem in the first place. And we know that there's evidence-based approaches such as housing first and harm reduction. And harm reduction, we all know what's been happening with that lately. The other thing that we have found And we've got several good examples here locally, such as Impact Junk, Goodwill Industries, Youth Opportunities Unlimited, where they have social enterprises. And when we were doing some of our previous work and evaluating social enterprises, we actually found that this was an excellent stepping stone. And especially these examples are people that, while they're in these programs, they are getting a livable wage. It is higher, but it also allows them to get into employment. In the case of youth, sometimes they've never had employment, and so they need to have that experience. And we've already talked about increasing social assistance. Next slide. So one of the issues, people have a hard time letting go of the idea that it's not about a person messing up and therefore being homeless, and that it really is a systems issue. And the one pilot, so we've done a lot of work around preventing discharge to no fixed address. NFA stands for no fixed address. And I'll come back to this because I got another slide. So let's go to the next slide. I'm just going to go through these ones fairly quickly. So basically, we're looking at critical points for intervention and looking at discharge as a potential critical point. And it's for many reasons. Sometimes what preceded the admission, particularly for psychiatric admissions, there may have been behavioral issues, something that they could have been evicted prior. We often found people can be evicted while in hospital for any chronic illness, because a notice could be put on their door that they don't see it because they're in hospital. If people are in hospital for a long time, that basic needs portion is subtracted from their income because they're in hospital, and theoretically the province is already paying for housing because you're in hospital, but the landlord is not going to keep it available. So it becomes a risk point. Next slide. So when we were hearing from people, like when I talked to people who lived experience, many of them were talking about the first time of homelessness was leaving hospital. When we were talking to the shelters, they were talking about the concerns about people coming from hospital. And that this is going back a few years when we were doing this. In the early 2000s, we were starting to look at this issue. And we decided, well, let's take a look at the literature. And amazingly, we only found 3 published papers that talked about this issue, who essentially all said it was a myth. In all cases, in some ways, they were looking at specific hospitals, and the hospitals that supported the research. The first one I found that had me suspicious, and I won't go into, but it was the Other London, and it was claiming that they followed people after psychiatric discharge for 6 months and found no one homeless, but they did lose 10% of their sample. But when I went to the shelter website in the Other London, lo and behold, there was a position paper there complaining about the people from that very same hospital coming to that hospital. The other 2 papers similarly, it wasn't a position paper, but in both these cases, we found photographs in the local newspaper the year before the study. So I think it illustrates how important it is to talk to people kind of on the ground in terms of what's happening. As an academic, literature and research is important, but we have to be very aware that there can be, particularly in these very fired kinds of situations, there can be other agendas. Next slide. So our very first study we did, well, the first one we did is we said, well, how often does this happen in London? So we went through the hospital databases here in London, as well as the shelter databases. And we actually found it was happening a couple of hundred times a year at that point, that somebody was one night in hospital and then the next night homeless. So we did an early pilot just to see how would we come up with an intervention, and then could we test this intervention. And I always say I had to stop. We were going to just take 20, and it was just to test out this intervention. We had to stop at 14 because it was like studying penicillin and syphilis. And what we were looking at in this pilot was people with no prior history of homelessness that only became homeless during this hospitalization, that they had stable income, and it was a planned discharge. So anyone who works in the field, this would be the easy of the easy. And we only followed them for 6 months because we were expecting, even though someone might have this temporary period of homelessness, they'd had no prior history, they had stable income, et cetera, that they would be housed. I was shocked to learn that the people who got the intervention, and I'll backtrack to it, that was that they had a housing advocate help find housing. And we worked with Ontario Works and Ontario Disability. All the participants would be having one of those sources, and they would agree to fast track the funds for first and last month's rent. So that would often take 2 weeks. Under normal circumstances, we sometimes had it in 2 hours, but it essentially, so for example, Ontario Works in the London office at that time had about 250 people working. I would call the boss if they were in the intervention group, and they would just quickly fast track it, just to sort of see, would that make the difference? So it's always this wild and crazy thing. What if the system actually worked? Was basically what this was. And it was a very minimal intervention because these people had no prior history. But what happened was the people who got the intervention were fine because their mental health problem had been identified. They had stable income. In fact, 4 of the 7 ended up being able to go back and be employed. The problem was with the 7 in the control group. 6 of the 7, and keep in mind, this was a flip of a coin, essentially. This was randomized between the 2 groups. 6 months later, they were still homeless, 6 of the 7. The 7th, technically, we counted as a success because our outcome measure was housed, not housed. I don't think anyone would say this was a success. She had a young child and was recruited into the sex trade on the way into a shelter, never been in the sex trade before, and 6 months later was still in the sex trade. This was where we couldn't go up to 20. I called ethics and said, I'm going to enroll people, but not include them in the study because we can't ethically give usual care, but usual care is what everybody else was doing. And then we pulled together our community partners trying to figure out how can we change this, because it's not feasible to have something where I call the boss of OW every time. So we ended up getting an algorithm that would work on the Ontario Works data, which we had to go through to Toronto to get it to work. Get permission to put an algorithm on their data so that if the request originated from either of our hospitals, it would automatically do the fast tracking. Next slide. So we had several versions of this. We had one problem where they changed the software, but we were able to switch by having, if it came from the designated person that was doing the advocacy at the hospital, it would automatically be fast tracked. So what the intervention now involves, and it's more generally available in both of our hospitals, that we have a dedicated housing advocates that do come in person to the hospital, that we have the income support people, particularly designated people from Ontario Works that are part of the team. The other good thing with Ontario Works is that if they should be on disability insurance, we can try to facilitate that while they're in hospital, and Ontario Works is very helpful with that. Sometimes we've gone in and we've seen a form was filled out 18 months ago, but they did not have a physician or primary care person to sign the form. While we're in hospital, we got lots of physicians and nurse practitioners. So by working as a team cross-sector, we can work together and get them on the proper income support. We link them into the Housing First programs, look at things like ID replacement, in some cases, If we can't get housing prior to discharge, we'll put them in it. We will at least find a shelter, et cetera. So essentially what we're doing is we're bringing community resources into hospital to help to work as a team to prevent discharge to homelessness. And depending on the time periods over our various studies, we started off with about a 97% success rate. With housing being less available, that went down to around 80%. We found our medical units tended to be a bit lower because they had very short lengths of stay, sometimes a single night in hospital. And we also now have a psychiatric version, a medical unit version, and a youth version. And if we can't find a home before discharge, we make sure they're linked in to the city programs. And then we've been following them to see if over time they do get housed by doing that and have had good success. Next slide. But I think the thing to keep in mind when you're talking about it being an individual, if someone became homeless or not, basically on the flip of a coin, whether you had a well-organized program or didn't have a well-organized program, it's clearly not related to the individual. It's related to the system. So one of the things we found, one of the things that really bothers me as someone working this area is we don't have accurate numbers around how many people are homeless. So because of some of this work preventing discharge to homelessness, and we were following people for a year, we knew they were at risk, but we also knew whether they were housed or homeless at different times. So we worked with people with the provincial data set to try to come up with an algorithm that would match up with what we were seeing so that we could look at health data to have a better idea of how many people were homeless, because all of our traditional methods of counting homelessness count on the person touching the homeless sector, and not everybody does. So we developed this system which suggests we might in fact have 3 times as many homeless people as what would be suggested by some of the national numbers. Next slide. And so with that national study, and I'm going to pick up the pace. Next slide. We looked at how this could be used across the country and what other data sets that we could bring in. And these are just some examples of where we've used the algorithm. For example, it was really handy having this algorithm during the pandemic because initially people who were homeless were not being prioritized for vaccinations. And we found that there was 20 times the risk of hospitalization if you were homeless. We've also done work pulling in, partnering with people to pull in coroner data to look at opiate deaths. And we found that right on the death certificate, 1 in 6 of the people, it was indicated the person was homeless. And in the more recent period, when we used our algorithm, this went up to 1 in 3. So how many times when people talk about the opiate crisis, have we talked about housing crisis? And how do you solve a problem if the people that it's mostly influencing are people who are dealing with homelessness? One of the, with our study that was mentioned at the beginning, where I went to 28 communities across the country, talked to people, one of the things people often talked about wanting to participate in the study in honor of their friend who died last week. And there could be many reasons, but one of the things I heard over and over about how the naloxone wasn't working, and it has to be kept at room temperature. Imagine trying to keep that at room temperature if you're on the street in either the heat or the cold. And what we found was that with these opiate deaths, 50% of the time when the person was homeless, they actually had somebody with them. Somebody was trying to help most of like half the time, and it didn't work. And we suspect that a lot of this is related to what people were telling us, that like people talk to us about trying to use the naloxone and it being frozen, trying to plunge it or trying to use the nasal and it was actually frozen. Dementia, same thing. We looked at the risk of dementia. Again, we were seeing this on the street, and we found that compared to other people living in poverty, people who were homeless had 70 times the risk of dementia, and compared to the general population, 90 times the risk. And I already mentioned that High study, which basically says if you discharge to homelessness, they're going to come back soon and sicker. Next. So again, talking about the solutions to the problem is to increase the housing units, address the income support levels, reconnect the policy, because it's the health policies, those income support policies, those housing policies all have to be connected. Housing First does work, and we have to recognize that when you're dealing with someone on one-to-one level, that it's not a simple failure of the individual. It is truly a system issue. Next slide. And so this is our point for questions. Sorry, I kind of raced around a bit there at the end, given we had a few little false starts. So any questions? Jeff. Hi, Jeff. Nice to see you again.
Hi, nice to see you. So Article 25 of the Declaration of Human Rights says housing is a human right. And with the Charter of Rights that guarantees the rights of disabled people, I'm wondering why we couldn't sue the government to provide housing for people based on the Charter of Rights and the UN Declaration.
I think that's a very interesting question. And when you see as well how it is very systematically people who have mental health problems, including addiction, like when we've looked at the stats, because if you're relying on the private market, knowing that people with mental illnesses are the most discriminated in society, they're not going to get that scarce housing. So I agree, it is a human rights issue for sure.
There was the other thing where during the 2009 crash, the subprime mortgage crash, the banks were bailed out in Canada using the CMHC 114 billion. And so I just, I wonder why we can't get 114 billion for housing. But anyhow, thanks so much for your talk. I really enjoyed it.
And it's really a pay you me now or pay you later, because again, when you look at the healthcare costs and the other costs by leaving someone homeless, it's not cheap. Like it's wrong for one to leave someone homeless, but even if you had someone so cold-hearted that they didn't care, it doesn't even make economic sense because of these healthcare costs. Like as I say, these major problems we're talking about in healthcare, we keep being blind to housing status, right? We can't solve any of those problems by being blind to housing status.
I'm not sure how to, do I put up my hand to ask questions, or I'm not sure how. I had a comment about the housing. I've been becoming increasingly annoyed by the advocacy for affordable housing and low-income housing. And I'll tell you why. Nobody's in the awful situation of the homeless, but what I'm hearing is we need money for to build a low-income housing and affordable housing. We need to build low-income housing and affordable housing. And what's happening is because contractors don't they don't make as much money off building the low-income housing. So they like to make a deal where they'll build so many, like a certain percentage of low-income housing, right? And I'm sure there's rules around that. But my real concern is being an environmentalist is new builds are incredibly destructive to the environment. I'm just going to read you something from the Circular Economy, the Canadian document for circular economy and resources. Approximately half of all extracted raw resources globally are used for construction material. The sector in Canada is extremely wasteful, with 40% of all urban solid waste coming from construction and demolition. Canada's construction industry economic sector generates $141 billion in GDP in 2020. So this industry, and I think we as social advocates for homeless just have to make sure we're clear that we're not advocating for new houses. We're advocating for homes, because I'm looking at the population of London and it is 422,000. And I'm looking at the number of homes and it's 174,000. So if you do the math there, you've got 2.4 people per household. So while using your analogy for deck chairs and music is, yes, I think there's a bunch of chairs in the closet is what I'm thinking.
Yeah.
Like,
Yeah.
not that we don't need new chairs. We don't need to destroy our environment, or we don't need to let builders use this homeless crisis as an excuse to make money and build homeless houses. We really need to be clear that we need housing. We need a lot of work to tell people, get people organized so that that we're not damaging the environment by
like the eye on the prize is the housing, and there's many ways of doing that. And even within the construction industry, I've seen some things about demolitions and how we need to be repurposing, like doing demolitions in a different way. And again, there's many, in some cases, in some communities, we may need, it's a numbers thing as to what's available. Sometimes it would be about how difficult, it's about the density, and how difficult would it be to put in a granny flat at the back or to rent a room. And a lot of this also comes under the municipal bylaw. What are we doing about Airbnbs? What are we doing around group homes? One of the things going across the country, I was appalled by the rent evictions generally, but some of these rent evictions included converting group homes where people may have been living for a decade with disabilities into residential properties or Airbnbs. One community I went to lost 6 group homes, but because that's considered like private enterprise and it's their own private property, nobody even keeps track of that. Nobody even says, well, you're not allowed to do that. And we literally saw people on the street, in some cases with developmental handicaps, with all kinds of long-term problems that have been rent evicted from these group homes, because we keep, instead of seeing housing as a community resource, we're seeing it as a private property issue, and that the person with that property has full rights to it, rather than thinking, even when you build a house, that's going to be there at least a century probably, right? So we need to be thinking of these things as community resources, and I really feel that we need to be thinking of things such as group homes. When I worked in Hamilton many years ago, Hamilton was the second city in Ontario, and there's very few since then that actually have a bylaw around group homes where they had to be registered, they were inspected, etc. In fact, when I worked in public health, that was one of my roles. But most communities don't even have a list of their group homes. So if someone is selling it, they don't know. That nobody knows, except for the people that are ending up on the street. And again, to then blame these individuals who end up in this situation is very difficult. But as I say, most of the cases when that happened, it was either converting them into a residential property so they could sell it at the high market prices that were going on, or else converting those individual units into short-term rentals.
Okay, thank you. Yeah, let's just be alert that we're talking about affordable housing and not affordable housing doesn't necessarily mean new housing.
It doesn't necessarily, but it could include it. I don't think we should pull it out.
I hear it as a new housing, like nobody even it's always like, yeah, it's new housing. Oh yeah, we could do something else, but that sounds too difficult. Let's just build new housing and let's pay the builder a whole lot of money because they need to you know, do all of their
A lot of communities are looking at vacant areas, and we have had some examples even locally, like around hotels that can be repurposed. We've seen that in a number of communities. The other thing is a lot of places with more people working downtown, a lot of office space. A lot of communities are looking at that office space and repurposing it for housing. So there are many alternatives where you can increase the housing.
Yeah, thank you so much.
Hello, can you hear me?
Thanks, Lynn. Yeah.
Yeah, right. Yeah, I was really struck by your saying that that ours is the only industrial country that has downloaded social housing responsibility the way it has. And
Yes.
I believe Austria, for example, I think there are other countries that have a very different policy. They
Oh, most countries had, and even before we downloaded, most of those European countries had a higher percentage of the total housing as public housing. So we would, it's not like we started off in a great place before we did the downloading. We were barely middle of the pack.
Mhm.
So with that change in policy and the loss of new public housing, we really lost it. But it's the kind of problem, it takes years to build up and create a crisis, but it's part of what built up to create the crisis we're in now.
Is the other part of this crisis, or another part of this crisis, the decanting of the folks who were in institutions such as London Psychiatric Hospital?
So in a longer presentation, sometimes I talk about that. In some ways, it was a perfect storm. People, I mean, it was a good news story in that we had starting in the 1950s, we had the beginning of antipsychotics. By the time we got to the 70s, we had very efficient treatments for mood disorders. So people who at one point there was no workable treatment for and had a very pessimistic outlook, now we're capable of, we're now recovering and able to live in the community. So, which is a wonderful thing, that people were recovering and did not need to have these long hospitalizations. But what we forgot was all the other things that were happening. And what happened was the period of deinstitutionalization, and this is why I was seeing people in this situation, overlapped with this downloading. And I can tell you, working in healthcare, we did not have our eye on that particular ball. Like we were saying, we need more community mental health services. If the people are not in hospital and they could be in community, that's wonderful. But they need community mental health services. But and having, as I say, talking to people at that time and trying to figure out how come we're running into this problem, I was not on the ball of this huge shift in housing policy that happened at the same time. So what happened was there was more people circling at the same time people were taking away chairs.
Yeah.
So it's not that deinstitution was a bad thing. And if you go back to the 1850s, when the psychiatric hospitals in Ontario were first being developed, and I've seen some historical write-ups on Hansard, and part of the reason for doing that in terms of the provincial debates was that people who with mental health problems were in the poor houses, and that this was an inhumane way of treating people with disabilities, essentially. And we had to create these asylums, these safer, more pleasant places for them to be. And now, what would be the modern equivalent of a poorhouse, if not a shelter?
Mm-hmm. Thank you.
On Nora.
Yeah, I'm sure you've heard the news about what City Council did yesterday. The mayor has been touting the whole of community response, and I'm turning on my video. Yes. Yeah.
No,
And
I have had
the
some
homeless hubs
involvement.
and so on.
Yeah.
And then council, some councillors are upset that there are going to be hubs in their wards and mostly in the eastern part of the city and not in the western part. And so they've voted to have no more hubs and to only fund the two existing hubs till the end of February. I didn't see the hubs on your list of solutions. Do you think this is a real problem, or
Well, as I say, it's an example of working together cross-sector. So I agree, like hubs is simply another example of how people work together. So our work around the youth version of preventing discharge to homelessness, like that group was sort of assimilated into that youth hub. But it's the, like, so different communities might call it different things, but it's the idea of you need the health sector, the income support sector, the housing sector have to sit down together, and that's essentially what the hubs are doing. So it's those are an example of exactly what I'm talking about.
So maybe I'm confused because the CBC and the London Free Press were talking about depots. Is a depot the same as a hub?
I don't know. I did not see the news today. You know, so if something happened more recently, yesterday, I'm not aware of that.
So
I'm sure I'll hear about it.
so you think there should be more hubs then?
I think what we need is we need to cross these sectors together, and hubs are a good example of how we can do that.
Okay, thanks.
Whether you call it a hub, a depot, or just a good idea, we can't do it in our silos.
Okay.
And that's the problem, is as I say, that's why working in healthcare, why I couldn't figure out initially why I was seeing people homeless that we had discharged from hospital, is because I didn't realize what was going on in the housing sector.
Great. Well, I'm not seeing more questions right now. I think we can thank our speaker. Did you want to have any concluding remarks or send it?
So thank you. I know your group does a lot of advocacy. I agree with the earlier comment about looking at it as a human rights issue, but I think the strategies that anytime you hear about a solution, I think what we need to be thinking of it, will it increase the chairs? Will it decrease the people circling? And advocacy around poverty, things that help people in poverty, as well as strategies that will increase those chairs in terms of housing, will both address the problem. Things that that take a more narrow view are more like just rearranging who would be homeless, but not changing the overall rate of homelessness. So if we're really going to change it, we have to increase the chairs or decrease the people circling, on ideally both.
Thank you.
Okay. Cheryl, on behalf of all of us, I want to thank you very much. You're obviously doing a lot of good work in this area, giving it a lot of thought and a lot of study. You've shared with us some of the research that we know adds to the bank of research that already exists, that tells us that, you know, homes are the starting place for anyone to have a healthy life. Your description of the health risks are heartbreaking. And anyway, so we really appreciate this national, historical to the present view you've given us of this crisis, and we wish you well in the work that you're doing.
Thank you. And if anyone runs into any women who are veterans who at any point have experienced homelessness, that's our latest group we're looking for. So let me know.
Right.
London is the first community, though, to end veteran homelessness, functional end. So we've done a really good job with that particular group. But again, we're doing this as a national study. Okay, thank you.
Thank you.
Bye.
Bye-bye. Thank you.
For attending our annual general meeting, and good night.